Your love is one of a kind. Your ring should be also. Veragio diamond engagement rings are designed with European elegance, unlike any other ring. Mervis Diamond Importers is the premier source for Veragio bridal rings and for the world's most brilliant diamonds, because your forever deserves extraordinary beauty. Our experts will guide you to the perfect engagement ring paired with a diamond that sparkles forever. Your ring should be as unique as your love story. Mervis Diamond Importers for Veragio rings and world-class diamonds. See us on mervisdiamond.com.
Welcome to the Medical Nursing Podcast, the go-to show for vet nurses and technicians passionate about internal medicine. I'm Laura Jones, a registered vet nurse, all-around medical nursing nerd, and your guide to breaking down complex medical diseases into simple, actionable chunks. Each episode is packed with knowledge and tips that you can start using right away to give even better patient care. So let's get started. Hello, and welcome back to another episode of the podcast, or a big welcome if this is your first episode. You are listening to episode 119 of the Medical Nursing Podcast, where we take complicated internal medicine conditions and turn them into confident nursing care. My goal is to give you the need-to-know information about the patients you are seeing in practice every single day so that you can spend less time with your head in a textbook and more time using your skills caring for your own patients. This episode is the first in a two-parter wrapping up our recent series revisiting gastrointestinal disease. And in this, we are talking about a disease that lots of us see very, very regularly, and that's pancreatitis. Now, I wanted to cover this one because pancreatitis is a condition that almost all of us have nursed, if not all of us, I'm sure. And despite that, it's a condition where a lot of what we originally taught has changed. Alongside that, we know that nursing care can make or break recovery for these patients, especially in those really severe cases. There's a lot to think about when caring for them, and with that, lots of different ways that we can use our knowledge and skills to give even better care to these patients. So this week, we're talking all about pancreatitis in dogs. We're talking about how it presents, how it impacts our patients, and how we can use more of our skills when caring for these patients in practice. And then next week, we are going to be turning things over to our cats, focusing on feline pancreatitis and also triaditis as well, and how the disease and nursing care is often very, very different in these patients. So with all of that said, if you are ready to get nerdy with me and start discovering new ways to support your pancreatitis patients, grab a coffee and let's get into it. So I'm going to start with a brief look back at A&P. Don't worry, I promise it will be brief. But I really do firmly believe that understanding the diseases that we see and how they impact our patients really begins with a look at what the body systems involved should do when they are functioning normally. So that's exactly what we're going to look at now. So looking at the pancreas, in dogs, it's a V-shaped organ and it sits in between the stomach and the small intestine. The right limb of the pancreas runs alongside the duodenum, so the first part of the small intestine, and the left limb runs along the stomach towards the spleen. The body of the pancreas, which is the area where both of those two limbs meet together, sits at about the level of the pylorus, so the exit out of the stomach into the small intestine. So if we think about the pancreas's location and all of those neighbouring organs that it's touching or is near to, we can start to see a disease that's bigger than just the pancreas itself, and this is actually especially true for cats. The inflamed pancreas in dogs with pancreatitis can actually start to irritate those neighbouring structures. It can start to upset the stomach, the small intestine, contributing to things like vomiting. It can also swell, and this can impact the flow of bile from the neighbouring gallbladder and bile duct, and it can also cause irritation of the fat surrounding the pancreas as well, which causes worsened pain and inflammation. The pancreas also shares its blood supply with the duodenum, and this is really important for us to bear in mind as veterinary nurses and technicians, because the perfusion of the pancreas, so the normal delivery of blood and oxygen, is really important in preventing pancreatitis, or in patients with existing pancreatitis, preventing it from getting worse. So making sure that that blood supply is as kind of tip-top and kept on top of as we possibly can is really important. If we look at the function of the pancreas, it has several key functions, and we primarily split these into endocrine and exocrine functions. Now, the endocrine ones are ones which we have discussed a lot on this podcast. It is things like the creation of insulin, glucagon, and other hormones via the endocrine cells inside the pancreatic islets. I'm not going to focus on these today because these are basically not really to do with pancreatitis, but if you do want to know more about those, then I would recommend having a little listen to some of the diabetes episodes that we have put out on the podcast. The exocrine functions are the ones that we need to think about in pancreatitis mostly. So 98% of the pancreatic tissue is dedicated to exocrine function. And the exocrine function is the creation and secretion of digestive enzymes as well as other substances. So we have two different types of exocrine cell in the pancreas. We've got acinous cells or acinous cells, which produce digestive enzymes. And then we have duct cells, and these duct cells actually produce bicarbonate, which is a buffer solution which helps to neutralise stomach acid. The digestive enzymes that the pancreas produces include amylase, which breaks down carbohydrates and starches into sugars. It includes lipase, which breaks down fats, and also proteases, which are enzymes that break down protein. There are different protein digestive enzymes. The one that we will probably all be familiar with the most is one called trypsin. And these enzymes, these protein digesting enzymes, are quite I don't want to say harmful, but their job is to break down proteins, right? And our body is made up of proteins. So they have to be very careful about how they are secreted and how they are activated so that they don't start breaking down the wrong stuff. So because of this, they are secreted out of the pancreas in an inactive precursor form called a zymogen. So in the case of trypsin, trypsinogen, the precursor, is secreted out of the pancreas, and it is then converted into trypsin as it enters the small intestine. So these zymogens are packaged really, really cleverly to prevent that inadvertent early activation. And it's substances called lysosomes that help to activate them. And there's also a special trypsin inhibitor called SPINK1, which sits kind of nearby, ready to neutralise any of those enzymes that have kind of been accidentally activated too early. So the pancreas does have some inbuilt safety mechanisms. The final step in activating those protein digesting enzymes is carried out by a substance called enteropeptidase, which actually lives on the entrance to the duodenum. So this means that theoretically, trypsinogen, the precursor to trypsin, our protein breaking down enzyme, can only be activated and turned into trypsin once it has physically left the pancreas and arrived in the small intestine where it's supposed to do its job. The digestive enzymes enter the duodenum via ducts. So in dogs there are two. So we have the pancreatic duct and then we have the accessory pancreatic duct. Cats are different. This is a big part of why we see things a bit differently in cats when it comes to pancreatitis, but we're going to talk more about that next week. One last thing on anatomy as well. In dogs, the pancreas is responsible for creating most of a substance called intrinsic factor in the body. An intrinsic factor is involved in the creation of vitamin B12. And while this is a little bit kind of outside of the realms of pancreatitis, it's worth mentioning because as a result of this, we can actually see low B12 levels in patients with pancreatic diseases, especially like chronic pancreatic disease. So that's the structure and the function of the pancreas. But what happens when the pancreas can't carry out those functions normally? So pancreatitis occurs when something triggers the premature activation of trypsinogen into trypsin inside the acinous cell inside the pancreas. In the vast majority of our patients, we actually never find out what that something was, so what that kind of triggering event was. The current understanding is that it happens through something called co-localization, which is where the zymogen granules and the lysosomes end up basically kind of together when they should be kept apart, and that then allows conversion of trypsinogen into trypsin. When all of this happens, the neutralising substance, that SPINK1 kind of inbuilt safety mechanism, becomes overwhelmed, meaning that we just have more and more activation, And then as more trypsin gets activated, that then kicks off all of the other digestive enzymes becoming activated as well. At that point, we get pancreatic autodigestion. So the pancreas will actually start kind of breaking down its own tissue. And this leads to things like edema, hemorrhage, inflammation, necrosis of the pancreatic tissue, and also necrosis of the peripancreatic fat. So the fat that sits around the pancreas. The secondary complications of this have really significant effects on our patients, and they actually explain why we see such severe systemic illness in patients with that really kind of nasty, awful acute onset pancreatitis. So the pancreatic inflammation and necrosis, as well as inflammation of those surrounding tissues and organs, actually will recruit huge numbers of white blood cells, specifically neutrophils, because the body responds to that inflammation. And those neutrophils then release inflammatory substances called cytokines, proteases, and also reactive oxygen species, and they release those into the circulation. So now, what was inflammation in the pancreas and the area around the pancreas is now systemic inflammation, because it's in the bloodstream circulating everywhere. So that's why we see things like SIRS, or systemic inflammatory response syndrome, in these patients. And this in turn predisposes patients to further complications like acute kidney injury, also acute injuries to other organs. So we can see ARDS, or acute respiratory distress syndrome, for example, and also coagulopathies, including DIC. This initial systemic inflammatory phase of disease is actually what the vast majority of our intensive treatment and nursing care is aimed at. So basically everything that we're doing within that kind of first 48 hours, when those patients are early in their disease process, early in hospitalisation and treatment, is really our kind of window to try and stop that patient tipping into systemic inflammation. Interestingly, it's also why we now can use novel treatments, if you have them available to you in the area of the world that you're in, actually to start treating the underlying kind of disease process itself, rather than just providing supportive care. And we'll talk more about those a bit later in the episode today as well. Another important area to look at when it comes to pancreatitis is acute and chronic pancreatitis. How do we know the difference? And how do we know which our patient has? And this is an area that I think many of us, myself included, have previously misunderstood for periods of time. And the reason for that is because we used to get taught that acute pancreatitis cases are those really nasty, severely affected patients, the ones that are hospitalised and needing intensive care, and that the chronic ones normally have much milder signs. And while that can be the case, actually distinguishing between acute pancreatitis and chronic pancreatitis is not something that we can do based on clinical signs or, how that patient looks in front of us. It's actually differentiated based on the histological changes that are happening inside the pancreas. So technically, to be 100% correct, we would actually need a pancreatic biopsy to figure out what type our patient has. So acute pancreatitis is characterised by neutrophilic infiltration. So at this point in time, this is more kind of a neutrophilic pancreatitis. We've got neutrophils infiltrating that pancreas as the primary inflammatory cell. We will often see edema and necrosis as well in severe cases in this form of pancreatitis. Critically, it's potentially reversible because the pancreas can recover with appropriate and prompt treatment. So with our acute pancreatitis, we want to kind of think of it as a bit like AKI, but for the pancreas, compared to chronic pancreatitis, which is a bit more like CKD, but for the pancreas instead of the kidneys. So chronic pancreatitis, unlike acute pancreatitis, is characterised by lymphocytic and plasmacytic infiltration, alongside fibrosis and atrophy of those acinar cells. So here we have got different cells that are kind of infiltrating the pancreas, causing inflammation, but alongside this, that inflammation has been there for a long time, meaning that we've got the kind of laying down of lots of fibrotic tissue, and the actual functional cells of the pancreas that are supposed to secrete digestive enzymes are kind of atrophying away. And this means that those changes are actually irreversible, they're permanent. Because chronic pancreatitis progressively destroys pancreatic tissue, these patients can go on to develop secondary diseases of the pancreas, such as diabetes or exocrine pancreatic insufficiency or EPI. Because basically, if our patients lose enough acinar tissue, they will not have the ability to create enough digestive enzymes, meaning that they will have EPI. And if they lose enough islet tissue because of the inflammation, they can't secrete sufficient insulin and they can become diabetic. So we can actually see diabetes mellitus secondary to pancreatitis in some patients. Interestingly, there was actually one study, and I've linked all the studies in the show notes for you, that found almost 2/3 of canine pancreatitis cases are actually chronic. So chronic pancreatitis is far more common than we actually think it is, mostly because these patients are often subclinical or more mildly affected, so they're less likely to turn up being admitted to the hospital for intensive treatment. We can also see acute on chronic disease, which is where there's a flare-up on top of established kind of fibrosis and long-term changes to the pancreas. So this means that the dog in front of us that looks like they've maybe come in for the first time, because this is the first time they've been hospitalised, could actually have been chronically affected for a long time without anyone knowing if their signs were mild and the client didn't notice them. So because of these changes, more recent studies have actually recommended that we rename acute pancreatitis to acute onset pancreatitis, because this phrase describes better what we can actually observe going on with the patient, which is that the clinical signs started suddenly, but we've not got a biopsy, we've not got histology to confirm a diagnosis of acute pancreatitis, so we have no way of saying anything about the histology, only the clinical signs. So that is the types of pancreatitis that we see in our patients, but let's talk about some of the risk factors, causes, and of course the clinical signs that we see. So most cases of pancreatitis in dogs are actually idiopathic, which is interesting because many of us, myself included, were previously taught that they were caused by things like the patient eating a really fatty meal, for example. That being said, there are some risk factors which we do need to know about as veterinary nurses and technicians, and these include breed alongside a few other risk factors that we're going to talk about. So looking at breeds, first of all, perhaps unsurprisingly based on what we've seen in practice, miniature schnauzers are significantly overrepresented when it comes to developing pancreatitis. This is because they do have some variation in the SPINK1 gene, and that is that kind of safety mechanism that mops up any of those prematurely activated digestive enzymes and stops pancreatitis kind of in its tracks, really. Alongside our Min Schnauz, we also have Yorkies, Cocker Spaniels, Dachshunds and Poodles who appear to be predisposed. And interestingly, English Cocker Spaniels may actually have their own distinct kind of autoimmune or immune-mediated form of chronic pancreatitis, so we can see English Cockers predisposed as well. Looking at a few other risk factors, hypertriglyceridemia or elevated serum triglycerides or lipemia is also an important risk factor. And so is Cushing's disease, hypercalcemia and obesity. And actually many patients that have Cushing's also are lipemic. There's also been a few medications that have been linked to the development of pancreatitis in dogs, including phenobarb when it's used in combination with potassium bromide, azathioprine, which is an immunosuppressant agent, and also L-asparaginase, which is often used alongside chemotherapy protocols for dogs with things like lymphoma. Dietary indiscretion is a recognised risk factor in dogs, and so is blunt force kind of trauma to the abdomen or trauma to the pancreas as well. Interestingly, pancreatic hypoperfusion under general anaesthesia is also a risk factor for the development of pancreatitis, and this is now thought to explain most cases of so-called kind of post-surgical pancreatitis. So for us as veterinary nurses and technicians, monitoring blood pressure under anaesthetic in any patient and making sure not just that we're kind of perfusing the kidneys kind of effectively, which is what we're all kind of looking out for, but also thinking about the importance of blood flow to the pancreas in these patients as well. Looking at clinical signs, the most common signs that we see include anorexia, vomiting, abdominal pain, lethargy, and also diarrhea. In terms of how often we see these, 82% of dogs in one study were documented to be anorexic, 80% had vomiting, 69% had abdominal pain, which surprises me, I thought it would be much higher than that, 46% were lethargic, and 42% had diarrhea. Now, the stats on pain particularly is really interesting because when we compare this to human pancreatitis, pain is reported in humans much, much more commonly. And when I say commonly, think over 90% of cases. And for me personally, I feel like it's quite unlikely that dogs have some sort of anatomical change that makes them way less painful when they have pancreatitis compared to us. Maybe actually it's more that even with how good we've got at recognising pain, there's still a way to go and that we are not identifying it anywhere near as often as it's probably present. And we've all got so much better with pain recognition and management over the years. Like we genuinely have. I say this after 20 years of nursing where bitch space still had butorphanol in their pre-med in my first practice. So we have made so many strides in recognising pain, treating pain, advocating for our patients. But this data highlights that maybe there is still a bit of a gap in its recognition in dogs with pancreatitis. And I think that this is an area for us as nurses and technicians that we are ideally placed to champion. We know the more obvious signs of pain that these patients present with. They present with things like the prayer position or a really tense abdomen, or maybe on examination, they're really resentful of their abdomen being palpated, or they won't allow you to kind of place the ultrasound probe on during a POCUS and have a look. But the more subtle signs, things like changes in vitals, restlessness, trembling, slight reduction in interaction, slight change in appetite, they're the subtle ones that we're really great at spotting. And of course, this will change from dog to dog because some of our patients will be much more stoic in their kind of nature than we perhaps give them credit for, meaning that some dogs will actually look really calm and settled in the kennel, but actually for them, they're quiet and painful. So as a general rule, if we think that a dog has pancreatitis, we should assume that there is abdominal pain and treat it until we have evidence to the contrary. Even giving a trial of analgesic and assessing response, even if it's a low dose, that's going to be a really great thing for these patients. In my experience and in my opinion, the general rule is if you think that this would be painful if you had it, then probably our patients need analgesia as well. This episode is brought to you by the Foundation Award in Medical Nursing. The Foundation Award is my very own 12-month on-demand course designed specifically for veterinary nurses and technicians who want to feel genuinely confident nursing their medical patients. If you've ever felt overwhelmed by a complicated case, or like you're just ticking boxes on a hospital sheet rather than truly understanding what's going on with your patient, then this course is for you. The Foundation Award goes beyond just throwing information at you. It gives you a real framework for turning your knowledge into hands-on, patient-centred nursing care that really uses your skills. You'll work through it in your own time with live case-based support built in, so you are never learning on your own. If you're ready to go from feeling stuck to leading care with confidence, then head on over to the website and check out the Foundation Award. You can find the link in the show notes. And now, back to the episode. Moving on from clinical signs to diagnosis, I want to talk a bit about the tests that we perform and the information that they give us. Now, of course, I say this knowing that diagnosing these patients is not something that legally is within the scope of our role as nurses and technicians. That being said, it's important that we understand the diagnostics that are available, what they tell us, and their limitations, especially in the case of pancreatitis, because they're not all perfect and they don't all give us the same information. And while we're not making the diagnosis, we are still heavily involved in the entire diagnostic process, from taking samples and even assisting or performing ultrasound scans in these patients in some cases. So looking at diagnosis, there's not one single test to confirm pancreatitis. So instead, what we need to do is look at a combination of the patient's clinical signs, examination findings, blood results, and also imaging. We will be performing all of the usual routine bloods in these patients, so biochemistry, haematology, electrolytes, and ideally also blood gas analysis if you have access to that in practice, alongside specific pancreatic testing and probably also an abdominal ultrasound. When it comes to pancreatic testing, pancreatic lipase is the most useful clinico-pathological marker that we have in practice. So specific PLI or pancreatic lipase immunoreactivity, which you'll see as CPLI or SPEC-CPL, is probably one of the most common tests we perform in pancreatitis. It has a decent sensitivity and a good specificity. So sensitivity, you're looking at sort of mid-80s to 90s in terms of percentage, and specificity, you're talking about kind of 66 to 77%. Now, I don't talk about sensitivity and specificity often on the podcast because they're a bit too kind of brain heavy, but they are important terms that I want to mention here. So sensitivity and specificity tell us basically how accurate our tests are. A highly sensitive test, if it's negative, is better at ruling out a disease, and a highly specific test, if it's positive, is better at ruling a disease in. So here, when we talk about PLI, we have a test which is more sensitive than it is specific, and this means that we can get some false positives. So the lower specificity number means that we can see patients without pancreatitis who still test positive. And this is because an elevated CPL tells us that pancreatic lipase is elevated in the blood, but it doesn't tell us that the pancreas is really angry and upset and unhappy and that it is 100% the reason why this dog is unwell. And that is why we use a variety of different tests in combination to confirm pancreatitis rather than relying on one alone. There are actually quite a few different tests that sometimes practices will use in place of pancreatic lipase. So we have the semi-quantitative SNAP CPL. That's the one that tells us if a patient has got normal or abnormal levels, but it doesn't give us a number. There's also the VCheck test and a test called DGGR lipase. And all of these are used similarly to give us an idea of pancreatic lipase levels, but they don't tell us exactly the same thing. I also do briefly want to mention as well amylase and lipase. So the bog standard amylase lipase that we get on our biochemistry results. They're still around, they're still parts of profiles in many practices, but we don't really worry too much about them, especially when it comes to pancreatitis. And the reason for that is there are lots of different things that can affect levels of both, not just pancreatitis. So a high amylase and lipase level is not specific for pancreatitis. Imaging is also often required in these patients, and ultrasound actually is pretty specific, especially when there is severe disease. However, that being said, its accuracy is very, very dependent on the images collected, and also we need to bear in mind that patients that have pancreatitis could actually still have quite a normal looking pancreas on ultrasound. So just because it looks normal on the screen doesn't necessarily mean that our patient doesn't have pancreatitis. So really all of these diagnostics are kind of just painting a bit of a picture, but they're not giving us like the definitive results, if that makes sense. And of course, alongside this, we're going to use our blood work to tell us about the general kind of overview of our patient. So how dehydrated they are, any electrolyte abnormalities, glucose levels, etc., etc. In terms of definitive diagnosis, the only way really to do that is with cytology or histology of the pancreas. But it's often not worth us doing that. And the reason for that is it rarely changes how we treat these patients. It can also upset the pancreas further. And many of these patients are pretty significantly unwell. And the last thing we want to do is take them to surgery and take a pancreatic biopsy, for example. So most of the time, it is that combination of imaging findings, blood results, and exam findings that gives our vets a working diagnosis of pancreatitis. And then we can start thinking about treatment and, for us as nurses and technicians, the care and monitoring our patients will need. So most of how we treat pancreatitis is supportive, and these patients often need incredibly intensive supportive treatment and nursing. There are 4 main pillars of supportive care, so fluid therapy, antiemetics, analgesia, and nutrition. And every single one of these we will be heavily involved in as veterinary nurses. There is also a more specific treatment for canine acute onset pancreatitis. And I do want to mention at the time of me researching and recording this episode, which is summer 2026, it is currently only available in Japan and North America. We're still going to chat about it though, because I think it's going to be interesting to see where this goes. Next time we talk about pancreatitis again on the podcast, maybe we'll all be using it. So the treatment for canine pancreatitis is a drug called fusapladib sodium, which I have probably just absolutely butchered, or to use its trade name, Panaquel CA1. So this is the first treatment that we have that targets the actual pancreatitis itself rather than just the consequences of the disease. It's a type of drug called an LFA1 activation inhibitor, which stands for lymphocyte function associated antigen 1. That is basically a really fancy way of saying it blocks neutrophils from migrating out of the pancreas and into other tissues. And so what this means is it's targeting that inflammatory phase that we chatted about right at the start of this episode. So it's stopping the inflammatory response from spreading out of the pancreas into the bloodstream and around the systemic circulation. Now, because it's not available where I am, I have absolutely no experience with it. But from the studies that I have read, the dose is 0.4 mg/kg as a slow IV bolus, once daily for 3 consecutive days. That was the dose that was used in studies and in clinical trials. And that trial, all of which is sort of referenced in the show notes if you do want to have a read, showed significantly faster clinical improvement in dogs that treated with this versus ones that didn't over that 3-day period. Now, as I say, this is a drug that's in its early stages of use. I'm really interested to see where this goes. But either way, it's great to see that we are getting more treatment options available for these patients alongside that all-important supportive care. But supportive care right now, especially if you are outside of Japan or North America, is going to be the mainstay of what we are treating these patients with. And the first sort of pillar in our supportive care plan for these patients is fluid therapy. This is important because the pancreas is incredibly sensitive to changes in fluid balance. When perfusion to the pancreas drops, the capillaries can become more permeable and kind of leaky, for want of a better word, so fluid can leak out of them more easily, vessels can spasm, and also microthrombi or little clots can also form. And all of this will further limit the delivery of blood, fluid, oxygen and nutrients to the pancreatic tissue. And this means that mild pancreatitis cases can worsen in the face of poor perfusion. So fluid balance and blood pressure monitoring, for example, are really important areas of monitoring and nursing care for us when we're looking after these patients. That being said, this doesn't mean that more fluids is always better, because there's still a risk of fluid overload, especially if you've got patients with severe systemic inflammation, where there's also a risk of acute kidney injury. So just like any other patient, thorough fluid assessments, calculating and addressing deficits appropriately, and ongoing monitoring of fluid balance after fluids have been corrected is absolutely essential. Next up, we have got antiemetics. So nausea and vomiting, we know, are significant complications in these patients. They risk delays in providing enteral nutrition, they risk aspiration, and they also risk further dehydration as well. And this means that addressing vomiting and also nausea is an essential part of caring for these patients. So we've got a few options of how we can do this. Meropenem is a really potent antiemetic, but it is less effective for nausea compared with how good it is for vomiting. So this means that sometimes additional antiemetic agents such as ondansetron that better target nausea can be considered, of course, under veterinary direction and prescription. There's also metoclopramide. Now, metoclopramide is not an effective antiemetic. It does not do much for vomiting, but it's a great prokinetic. So if the guts are slow, if your patient develops ileus because of their pancreatitis, it can help speed them up, and that will help to reduce nausea. However, metoclopramide works in the body on dopamine pathways, and these pathways are also thought to play a role in pancreatic blood flow. So this means that we do need to use metoclopramide a bit carefully in patients with pancreatitis. The other thing that I want to mention on the topic of nausea and vomiting is that a dog who isn't actively vomiting can still be profoundly nauseous. Lip smacking, drooling, turning their head away from food, exaggerated swallowing, these are all things that we commonly see in these patients, even in the absence of vomiting. And if you've got a patient showing signs of this, they also will need antiemetics to treat their nausea. And for us as nurses and technicians, we are ideally placed to look out for these signs and flag them with the vet if we're concerned that our patient may need some additional treatment. And then we have got analgesia. Analgesia is an essential consideration in all patients with pancreatitis, and many cases will need potent agents to manage their severe abdominal pain. And for us as vet nurses and technicians, our role in managing this, monitoring these patients, and also advocating for changes to their analgesic plan is absolutely essential. In most cases, these patients will typically need full mu opioids such as methadone or maybe even fentanyl, unless they only have mild pain, where maybe something like buprenorphine might be more appropriate. Non-steroidals should be avoided in all pancreatitis patients due to both the GI signs that we see in pancreatitis and also the risk of acute kidney injury in a patient that has got concurrent systemic inflammation, dehydration, and or hypovolemia. When we talk about analgesia, though, we do need to bear in mind that opioids can contribute to ileus. Where this happens, this will slow the GI tract down, it impacts nutrition, and it increases nausea and risks regurgitation. So for this reason, we actually do sometimes use opioid-sparing protocols or add in other agents, so using a multimodal approach so that we can lower the opioid dose. Those other agents include things like lidocaine, ketamine, and even local blocks, so tap blocks, epidurals, even epidural catheters, for example. These can all be great options for these patients. And the last pillar that we're going to talk about is nutrition, and specifically early enteral nutrition. So what we should be feeding dogs with pancreatitis, when we should be feeding them, and how we should be feeding them. And nutrition is probably the area that has evolved the most in the way that we support these patients. And it's also an area that all of us truly champion in practice as nurses and technicians. When I first began training, we used to nil by mouth for these patients. I would come in the morning and there'd be an NBM on the hospital sheet for these cases. And the thinking behind that at the time was that for at least a short period of time, the pancreas needed to rest before further food was given, because food would aggravate it, it would activate more of those digestive enzymes, and that would worsen the ongoing cycle of inflammation and necrosis. And that was the best that we were doing with the information that we had at the time, but in reality, this couldn't be more wrong. And the reason for that is we know now that pancreatic secretion actually decreases early in pancreatitis. And that's because those acinar cells or acinar cells, those ones that create the digestive enzymes, they can't respond properly because they're damaged or they're injured. So actually resting the pancreas doesn't have any significant benefit because those cells can't produce sufficient digestive enzymes to kind of upset the balance even more anyway. On top of that, withholding food will actually do more active harm to our patients. It causes damage to the enterocytes, so those cells that line the small intestine. That in turn will cause dysfunction of the GI barrier, which risks bacterial translocation. And also, we know that withholding food changes the microbiome as well, all of which we've chatted a lot about over the last few episodes of the podcast. Early enteral nutrition has been shown to be safe and well tolerated, even in dogs with severe acute onset pancreatitis. And on top of that, it has been shown to improve return to voluntary food intake, all while reducing gastrointestinal complications. In terms of contraindications, the only real ones to providing early enteral nutrition in pancreatitis are patients that have uncontrolled vomiting, even in the kind of face of appropriate antiemetics, severe ileus, which means that the guts can't do anything with the food and it just sits there, or really bad pain that clearly worsens when a patient is fed. So this means for us that early enteral nutrition is a vital consideration when nursing these patients. As soon as we are happy that the pain and vomiting is controlled, we want to get nutrition on board. We want to be performing regular nutritional assessments, tempting patients to eat, and intervening with a feeding tube where needed at an appropriate point, ideally no more than 3 days of anorexia in total. When we are feeding these patients, we want to keep their calorie intake appropriate, so working up to 100% of RER over an appropriate time period, but not exceeding it. And also keep individual meals small, so around sort of 5 to 10 mils per kilo per feed. In terms of what to feed, in dogs we want a low-fat, highly digestible diet. And when I say low-fat, I'm talking less than 20 grams of fat per 1,000 calories. We also want to avoid dense, kind of high viscosity, thick fibre content in patients with vomiting or ileus because it slows gastric emptying. And although we wouldn't be kind of routinely reaching for urinary diets in these patients, if you are in the situation where you have a dog on a Urolift dissolution diet that comes in with pancreatitis, do just be aware that these diets are quite high in fat naturally, and so we should ideally avoid these in these patients. And so we might have to have a bit of a discussion about what's the biggest problem right now and maybe look at an alternative for the Urolith dissolution if needed. So those are the 4 main pillars of how we treat these patients, but I do also want to mention a few ways that we don't routinely treat these patients. And interestingly, I think these are all treatments that we've probably seen used or maybe even used ourselves when nursing patients with pancreatitis. So antibiotics, antacids, plasma transfusions and colloids should not routinely be used in patients with pancreatitis. The reason being, antibiotics are not indicated routinely, but they are recommended in patients that have evidence of bacterial translocation, concerns for sepsis, or a documented infection in the body. Proton pump inhibitors, so this is antacids like omeprazole, should only be used if there's actual evidence of GI bleeding or esophagitis. They can actually worsen things like the microbiome and cause diarrhea if they're used inappropriately. And also plasma and colloids don't have sufficient evidence behind them to support their routine use in patients with pancreatitis. There are some questions about whether we should or shouldn't use steroids in patients with pancreatitis, and there have actually been some studies that have suggested benefits in patients with pancreatitis who were treated with corticosteroids. There's not enough evidence really out there at the moment to kind of comment more than that, and this is maybe an area that we will see change in the future, so we might end up starting to use steroids more often in these patients. Who knows what will happen? I want to finish today's episode by looking not just at the specific nursing tasks that we've mentioned, but by talking about our kind of overall role in managing these patients. And this is one that I'm especially passionate about because we can and should play a key role in the overall support and management of these cases in the hospital. Nurse-led medical care is something that I will forever be shouting about from the rooftops, as you probably know by now. And there are lots and lots of different ways that we can have more autonomy in our nursing without kind of acting outside of the scope of our role or treading on our vet's role. So on admission, we are often involved in clinical history collection, or at least we can be and should be. And for these guys, this should include diet, treats, table scraps, supplements, every medication the dog is on, recent trauma, concurrent diseases, anything like that. We're also often the people who are responsible for triaging these patients when they present as emergencies, or looking out for subtle changes when we're monitoring these patients in the hospital. We can use our knowledge, our skills, and also our ability to know what could happen with our patient to think outside of the box and look for changes beyond the treatments that are written on the hospital sheet. So whatever our vets has asked us to do, of course, yes, absolutely, that's the treatment we're going to carry out. But it doesn't just have to be that. We can be thinking about what could happen with this patient. What nursing care might they benefit from? How else can I use my knowledge of their disease and my skills to give them better care? We can do things like perform regular hydration assessments, even if the patient isn't directly written up for them. Just do it at the same time as the TPR, for example. We can chart the patient for more regular pain scores if you want to keep an eye on that pain level more often. We can dot the patient up for more weight measurements more frequently, maybe if we're worried about fluid overload. We can perform nutritional assessments, we can calculate intake, and we can do things like advocate for feeding tube placement. We can actively look out for complications rather than dealing with them after they have arisen. And then we can continue all of that care at and beyond discharge. We can talk to clients about low-fat diets if they're indicated at home, and also what low-fat actually means. Create feeding plans for clients to follow. We can tell them what to monitor at home. And of course, we can then, even after that, check things are okay just a couple of days after the patient goes home. There are so many ways that we can do more with these patients in practice. And with that, there are more ways that we can use our knowledge and our skills to give even better care to our patients. So that just leaves me to say a massive thank you for joining me for another episode of the podcast. Of all the podcasts out there, I am so grateful that you have given your time and chosen to learn with me. It means more than you know. If you found this episode helpful, then be sure to send this to another nurse or technician that you work with who would also find it useful. And has anything in this episode surprised you? I would love to hear. Is there anything that you're doing differently in practice? Is there anything that you're going to do differently with your patients or how you nurse them as a result of what we have chatted about today? Pop me a message over on Instagram. I love hearing from you. I love chatting with you. I love talking all about the cases you're seeing and helping you use more of your skills. So a huge thank you once again from me for listening. Take care of yourselves, have a fantastic week, and I look forward to speaking to you very, very soon in a future episode. Bye. If you've made it this far, then thank you so much for listening all the way to the end of the episode. And I have one more thing to ask of you before you go today. I would love to hear from you. Yes, you. I love hearing about the cases that you're seeing, the skills that you're using, and the conditions that you want to learn more about. Drop me a DM on Instagram. I'm at Vet Internal Medicine Nursing, and don't be shy. Come on over, say hello, and tell me a bit more about you. Talk to you soon.